Good afternoon, everyone, and welcome. My name is Tracy Newman. I am a pediatrician and the medical director at the North Dakota State University Center for Immunization Research and Education. Today, I have the pleasure to introduce Dr. Rebekah Tompkins, who will be presenting this webinar titled Bump Up Provider Confidence, the Critical Role of Vaccines in Pregnancy. Dr. Tompkins is a graduate of North Dakota State University and the University of North Dakota School of Medicine and Health Sciences in Grand Forks, North Dakota. She completed her residency in obstetrics and gynecology at Banner Good Samaritan in Phoenix, Arizona. She is currently an OB/GYN at Sanford Health in Fargo, North Dakota, where she has been practicing for 14 years. Dr. Tompkins, you can begin.
All right, thank you so much, Dr. Newman. And I realize that everybody's time is their most valuable asset, so I really appreciate that you're spending some of it with me today. We'll just jump right in. I have no disclosures. So our objectives today, upon completion of this course, we want participants to be able to recognize current recommendations for vaccination during pregnancy. We'll be focusing on Tdap, influenza, COVID-19, and the RSV vaccines. We want you to be able to recall current recommendations for RSV immunization in infants, describe the burden of vaccine-preventable diseases and benefits of vaccination for pregnant people and their infants, and review tools to increase provider confidence in making a strong recommendation for vaccination and addressing patient vaccine-related questions. So just as a quick review, we all know that the pregnant body goes through many different changes during pregnancy. Specifically, there are immunologic adaptations that occur. There are hormonal, circulatory, and mechanical adaptations that also occur. And these lead pregnant women to being more susceptible to infections that could otherwise be easier to fight off. And so vaccines during pregnancy can help to protect both mom and baby from vaccine-preventable diseases. So how are we doing with vaccinations during pregnancy in the United States? Well, this shows the results of a survey that was done among pregnant women during the 2023-24 flu season. So just under half of women reported receiving the flu vaccine before pregnancy or during their pregnancy, and that rate was similar to the 3 previous seasons. However, since the COVID-19 pandemic, influenza vaccination during pregnancy has actually declined and is about 9 to 21% lower than pre-pandemic seasons. Tdap coverage was 60%, and this is similar to coverage in the season prior, but this has actually increased significantly, almost 15% since the 2021-22 season. With COVID during the 23-24 flu season, women that were pregnant before or during this time were only at 31% with an updated COVID-19 vaccine. So the answer to the question, how are we doing? Well, we've got some room for improvement. So a recent review suggests that vaccine safety is the most commonly cited obstacle for pregnant women to get the COVID, flu, and pertussis vaccines during pregnancy. And this shows that the good news is that not every pregnant patient is hesitant. So let's look at what gets pregnant people to get their vaccination. So this was a study that was done asking women to rank the top 3 reasons for getting a flu, Tdap, or COVID-19 vaccine during pregnancy. Across the board, my healthcare provider recommended it is the top reason for getting vaccinated. And this shows that what we recommend does actually make an impact. But interestingly, a recent survey of healthcare providers shows that half of healthcare providers do not or only sometimes recommend COVID, flu, or RSV vaccines to their adult patients. So the number one reason that was given was that they assume that patients just aren't going to want it or they're going to refuse the vaccination. But again, going back to the other study, the number one reason that patients get the vaccine is because we recommend them. So it's important that we recommend them. And this kind of reminded me of the Wayne Gretzky quote of, "You miss 100% of the shots you don't take." So a quick knowledge check here. Which of the following is the most commonly cited obstacle for COVID, flu, and pertussis vaccination during pregnancy? and it is C, vaccine safety. So moving on to the Tdap vaccine during pregnancy. So the Tdap vaccine is given between 27 and 37, or excuse me, between 27 and 36 weeks to help provide protection for both mom and baby. With moms, it's protecting against tetanus, so that if they get a cut or a wound, that could lead to severe complications. It helps protect against diphtheria, and that is, affects the, it's a throat infection. It can cause breathing issues, heart failure, and even paralysis. And it helps protect against pertussis or whooping cough. And it decreases the chance of the mom getting it or spreading it. And whooping cough during pregnancy can be just miserable. It can cause prolonged coughing fits and breathing difficulties, and that can compromise the oxygen flow that can go to the baby as well through the transplacental transfer. With infants, we're mainly looking at the pertussis part of this vaccine for protection. The babies can't receive pertussis during the first 2 months of life. And so by vaccinating mom, you get the transplacental transfer of the pertussis antibodies to the fetus. And this offers that vital protection during those first few months of life when the baby is most vulnerable. Looking at this slide, it's showing us that pertussis is cyclic in nature. We get a spike every 3 to 5 years. Transmission is so easy for whooping cough. It's respiratory droplets, it's person to person. With this graph, you can see that cyclic nature. You can see a big drop off between 2020 and 2022. And this, of course, is likely due to the increased precautions that were taken due to the COVID-19 pandemic. But boy, pertussis is having its time right now. We are really seeing a resurgence of it. There's a preliminary data that showed that 6 times as many cases have been reported in as of December 14th, 2024, as compared to the same time in 2023. It's been so much so that the North Dakota Department of Health and Human Services put out a call to action requesting that prenatal care providers urge vaccinated pregnant patients to get the pertussis vaccine. Since August of 2023, there have been 124 cases of pertussis. 8 were hospitalized, and 7 of these were infants that were less than 12 months old. So this is really concerning because these little babies often can require mechanical ventilation, and it can even result in death. So these cases are really increasing in North Dakota, and one of the best things that we can do to help prevent this is to get people vaccinated, especially our pregnant moms, to help those infants after birth. So among infants who get pertussis, half end up in the hospital. Of those that end up in the hospital, 1 in 5 will get pneumonia. And of those hospitalized for pertussis, 1 in 100 will actually die of the infants. So it's very scary. These are really, to me, they're pretty frightening numbers. Most deaths were among infants, and they're those little ones that are just too young to be protected by childhood vaccine. And this graph kind of shows that. So this graph shows the number of hospitalizations by age of infant and months in relationship to administration of the Tdap vaccine. So just a quick reminder, the Tdap vaccine is that initial 5-dose series. The first 3 are given at 2, 4, and 6 months, and then again at 15 to 18 months, and then 4 to 6 years. The Tdap is what is given to older children and adults. So since the first dose of the Tdap isn't given until 2 months of age, and the actual full protection isn't given until 6 months of age in that 3rd dose, this really leaves a window of significant vulnerability for young infants. And that's really what this graph shows. Young infants account for 70 to 90% of all pertussis attributable hospitalizations and deaths. I started practicing here in Fargo in 2010, and so I saw this all come about. In late 2011, the Advisory Committee on Immunization Practices, or ACIP, recommended that unvaccinated pregnant women receive the Tdap vaccine help protect infants during the early months of life. In 2012, they extended this recommendation to include every pregnant woman should get a Tdap vaccine for every pregnancy. So the CDC recommendation is that all pregnant women get the Tdap vaccine between 37 and 36 weeks of pregnancy, preferably the earlier the better in this window, just so that they have time to make those antibodies and get them to the baby. And we just don't know exactly when those babies are going to be born, so the earlier the better. And this is supported by the American College of Obstetrics and Gynecology, the American College of Nursing Midwives, the Academy of Pediatrics, the Academy of Family Medicine. Everybody supports this recommendation. Because of maternal transfer of the antibodies to the baby before birth, infants born to mothers who received the Tdap vaccine in pregnancy have a 69 to 93% reduced risk of getting pertussis. That's really, really good numbers. So doing a quick knowledge check here, true or false, young infants account for a minority of all pertussis attributable hospitalizations and deaths in the United States. And this, of course, is false. So moving on to COVID-19, which we've all talked about a lot over the last few years. So when the COVID-19 trials were first done for the vaccine, they did not include pregnant patients. And so there was limited safety data among pregnant people and their infants. And there was initially some differences between the CDC recommendations and the FDA-approved vaccine package inserts. And so this did contribute to some consumer confusion and a bit of spread of inaccurate information. But we now have some time and we have more numbers. And so we do know that pregnant people and recently pregnant people have a 2.5 times increased higher odds of ICU admission from COVID than the non-pregnant women. And they also tend to get more sick. So they can get severe illness like acute respiratory distress syndrome, sepsis, ICU admissions, mechanical ventilation, even death. And they can have adverse pregnancy outcomes like preterm birth and stillbirth. And these tend to be across the board. When we're looking at infants, over 75% of babies hospitalized with COVID-19 were born to women who did not receive the COVID-19 vaccine. There's also good news for those women that didn't have a chance to get the COVID-19 vaccine during pregnancy or didn't want to. There are recent reports that have shown that breastfeeding people who received the COVID-19 vaccine get the antibodies into the breast milk, and these can go to the babies and help protect the babies that way as well. So good to get that vaccine at any time. So just in review, the CDC recommends that everyone ages 6 months and older should get an updated COVID-19 vaccine. This includes people who are pregnant, people who are breastfeeding, people that are trying to get pregnant now or who might want to get pregnant in the future. And this aligns with all of the other organizations that are involved with pregnancy. And just a note, everyone 6 months and older should get this vaccine. And by doing that, we can also get that herd immunity, which helps protect young infants that can't get the vaccine as well. Looking at the safety of COVID-19 vaccines in pregnancy, there have now been many studies done, including hundreds of thousands of people around the world. And they've shown that the COVID-19 vaccine before and during pregnancy is safe, effective, and beneficial to both the pregnant person and their baby. The data on the safety of the vaccines is reassuring, and the benefits of receiving a COVID-19 vaccine seem to outweigh any potential risks of vaccination during pregnancy. The studies show no increased risk for complications like miscarriage, preterm delivery, stillbirth, or birth defects. And they actually reduce the risk of severe illness and other health effects from COVID-19 for people who are pregnant. And in fact, they may help prevent stillbirths and preterm delivery. All right. So this was a large cohort study out of Sweden and Norway, and it looked at just under 100,000 infants who were exposed to the COVID-19 vaccination during pregnancy. And this found that vaccination during pregnancy was not associated with any increased risks of neonatal adverse events. And in fact, it was associated with a lower odds of neonatal intracranial hemorrhage, cerebral ischemia and hypoxic ischemic encephalopathy, and neonatal mortality. So compared to unvaccinated pregnant people, those who received a bivalent COVID-19 vaccine had an estimated 61% reduced risk of emergency room or urgent care visits in pregnant women. It had a 56% reduced risk of hospitalization in infants that were less than 3 months old, and a 38% reduced risk of hospitalization in infants that were 6 months old. And this graph really shows the results of the CDC research analyzing data among COVID-19 hospitalizations for infants that were less than 6 months old. And as you can see there, the dark blue represents infants whose mothers did not have a recorded COVID-19 vaccine during pregnancy. And the light blue shows those that did receive, whose mothers did receive a COVID-19 vaccine during pregnancy. And I think this graph speaks for itself. It really shows the effects of that vaccine during pregnancy. Moving on to RSV, just a quick review. RSV is a single-stranded RNA virus, and almost all children are infected by 2 years of age with RSV, but reinfection is common. It's an acute respiratory tract illness, and it can affect people of all ages, but the clinical manifestations vary with age, health status, and whether the infection is primary or secondary. RSV infection, it's usually just primary support, but people can get very, very sick, especially the youngest among us, and often can require mechanical ventilation and can lead to apnea. And so it's really important to help protect these little ones by getting vaccinated during pregnancy. Each year in the US, in the less than 5-year-old age group, RSV is associated, RSV is associated with 100 to 300 deaths, 58,000 to 80,000 hospitalizations, almost 520,000 emergency room visits, and 1.5 million outpatient visits. An estimated 79% of children younger than 2 years old who are hospitalized with RSV have no underlying medical condition, and RSV is the #1 cause of hospitalization among US infants. Most infants are infected during the first year, about 68% of them, and nearly 97% have been infected by age 2. So there was a recent retrospective cohort study published in JAMA Pediatrics in December of 2023, and this showed that pediatric hospitalization rates were higher for RSV than for COVID or influenza, and ICU rates were also the highest for RSV. The odds of newborns and infants less than 1 year old being hospitalized for RSV were 11 times higher than for those with COVID. So the CDC recommends the use of one of two tools to protect infants from getting very sick with RSV. They can get an RSV vaccine given during pregnancy, or they can get an RSV immunization given to infants or older babies, and most infants will not need both. So let's look at the maternal RSV vaccine. So this is called Abrysvo. It's the first FDA-approved vaccine for use in pregnant individuals, and this is to prevent lower respiratory tract disease caused by RSV in infants from birth through 6 months of age. It's approved to be used at 32 through 36 weeks of gestation during pregnancy, and it's administered as a single dose. There was a recent study from Mass General Brigham Hospital in Boston, and it shows that the earlier in the time frame that it is given, the better. And again, for the other vaccines we've talked about, because of the ability of the mom to be able to make those antibodies and get them to the baby. The safetiness and effectiveness is being evaluated in ongoing trials. And the preliminary data from this has shown that there is an almost 82% reduced risk of severe lower respiratory tract disease within 90 days of birth, and almost 70% reduced risk of lower respiratory tract disease within the first 180 days of birth. Looking at the infant RSV immunization, this is called nirsevimab. And who should get nirsevimab? Well, this is recommended to be given to infants that are younger than 8 months of age who were born during or are going to be entering into their first RSV season if their mother didn't receive the RSV vaccine during pregnancy, or if the mother's RSV vaccine status is unknown. It's also recommended to be given if the infant was born within 14 days of the maternal RSV vaccination, because there'd be concern that there wouldn't have been enough antibody passed from mom to baby yet at that point. And it is recommended for some children ages 8 months through 19 months who have an increased risk for getting severe RSV disease and are entering their second RSV season. So in most regions of the United States, RSV season typically starts during the fall and then it peaks in the winter. In general, women who are 32 through 36 weeks pregnant during this September through January should get 1 dose of the maternal RSV vaccine, Abrysvo, to help protect their babies. The nirsevimab vaccine for infants is recommended to be given from October through March. And that little bit of a difference is so that as it's given to mom, she can make the antibodies and then get them to the baby. That's why there's that little bit of difference there. The RSV season does vary a little bit in the United States, particularly in those places that are on a little bit outlying, like the Alaska or Florida, or those outside of the continental US. They tend to have an earlier and longer RSV season, and the CDC website is a good resource to look if you're practicing in one of those areas. This is a very new study that was just published in JAMA in 2025, and it was looking at 647 pregnant individuals. 64% were eligible pregnant individuals received the maternal RSV vaccine, and 70.1% of eligible neonates received nirsevimab. This translated to more than 80% coverage against RSV during all but the first month of the study when that was first coming out. And it showed that there was no significant association between maternal RSV vaccine and preterm birth in a nested case control study. And figure 1 over on the left shows the monthly proportion of newborns delivered who, during the study period, who received protection against RSV either through maternal vaccination at least 14 days prior to delivery, or through the infant getting nirsevimab prior to being discharged from the hospital. And the respiratory syncytial virus coverage exceeded 80%, like we said before. This is wonderful coverage for our infants. Looking at the efficacy of the vaccine, this was a phase 3 clinical trial that was published in the New England Journal of Medicine. And it showed that maternal RSV vaccination reduced the risk of the baby being hospitalized for RSV by 68% and having a healthcare visit for RSV by 57% in the first 3 months after birth. And in that same trial, the RSV vaccine reduced the risk of the baby being hospitalized for RSV by 57% and for having to see a healthcare provider by 51% within the 6 months after birth. Looking at safety of the RSV vaccine, for the maternal RSV vaccine, the most common side effects were pain at injection site, headache, and myalgia, but there were some concerns that were brought up about preterm birth. And so the initial study that was done by Pfizer used pregnancies that were between 24 and 36-week gestation. There were more preterm births that were observed among the maternal RSV vaccine recipients than the placebo recipients. However, this was not statistically significant. People in this trial who received either the maternal RSV vaccine or the placebo during weeks 32 through 36 showed the preterm birth occurred in 4.2% of the vaccinated recipients compared to 3.7% of the placebo. So the available data are insufficient to establish or exclude a causal relationship between preterm birth and Abrysvo, But initially, Pfizer had been looking to get this vaccine for 24 to 36 weeks of pregnancy, but due to an abundance of caution, the FDA only approved the vaccine for uses between 32 to 36 weeks of pregnancy. And babies exposed to the RSV vaccine in the third trimester are not at an increased risk of preterm birth or other post-birth outcomes. And that was according to this study that was published in JAMA Network Open last year. The vaccine was found to be safe and protective in the real-world setting, and there were no significant differences in rates for for gestational age births or stillbirth. But there was an increased risk of overall hypertensive disorders in pregnancy with the RSV vaccination in a time-dependent model, and that showed that 20.1% in the vaccine group and 18.1% in the unvaccinated group. And so this is something that is being looked at further and is something that we need to take into consideration when we are recommending these vaccines for pregnant patients. GlaxoSmithKline had a vaccine that they were showing that was very similar to the Pfizer Abrysvo vaccine, but this trial actually was stopped early. It showed that preterm births in the vaccine group were more than the placebo group, with 6.8% in the vaccine group and 4.9% in the placebo group. Of the preterm births, 5.5% in the vaccine group were either very early at less than 32 weeks or extremely early at less than 28 weeks. And this was compared to 2.3% in the placebo group. Because of these early and very early deliveries, the neonatal death risk was higher in the vaccine group. And so because of this, the trial was stopped and this vaccine has never been released. The follow-up that was done on this, it was published in the New England Journal of Medicine. It was a phase 3 randomized controlled study, and it showed that the maternal RSV vaccine, it was effective, but that there was the risk of preterm birth, and it was higher with the vaccine. And so, again, the mechanism of increased risk and whether or not it was a true risk remains unknown, but the GlaxoSmithKline vaccine has not been released. So looking at other vaccine safety outcomes, they're overall uncommon, but as we mentioned a little bit before, hypertensive disorders of pregnancy did occur in 1.8% with the maternal vaccine versus 1.4% with the placebo vaccine or placebo. And the following conditions, which are often also associated with preterm birth, occurred more frequently in infants born to mothers who received the RSV vaccine compared to the placebo. That was preeclampsia, low birth weight, and jaundice. But when we're looking at the initial study, that was again that 24 to 36 weeks, and the low for birth weight and jaundice was more in the earlier of that, and the FDA approval is just for the 32 to 36 weeks gestation for this, with the hope to reduce the potential risk for preterm birth and the complications that could arise with that. One of the ways the safety vaccine is evaluated is through the vaccine safety data link. This is a collaborative project between the CDC and healthcare organizations across the US. This chart shows a matched data analysis of that VSD data. This is from October 2024, and it showed that the maternal RSV vaccine is not associated with an increased risk for preterm birth or infants with small for gestational age. Moving on, let's take a look at the effectiveness of the infant vaccine for RSV, the nirsevimab. The observational data indicates that during the first RSV season after approval, which was just this last season, nirsevimab is working as expected among infants during their first RSV season. So this is very, very good news. In infants that received the nirsevimab, the approximately 70% were less likely to visit a healthcare provider because of RSV. There was 70 to 90% decrease or less likely to be hospitalized with RSV, and 80% less likely to be admitted to the PICU for RSV. So one of the questions I got a lot in my office this year was, should I get vaccinated or should I wait to have my baby get it? And there are definite advantages and disadvantages to both vaccines. And so just looking at those a little bit, with the maternal RSV vaccine, one of the advantages of this is that the baby is going to get protection immediately after birth, as long as it was given at least 14 days prior to birth, and it reduces the number of vaccines that the infant needs to get at birth. Disadvantage is that there could potentially be reduced protection in some situations, like if the mother is immunocompromised or the baby is born too soon after vaccination. In both those situations, there just won't be enough antibodies given to the baby to provide protection. And then there's also this potential risk for hypertensive disorders of pregnancy. The most recent data is reassuring, but it is still something that I was discussing with my patients about these vaccines. With the nirsevimab, the advantage is that with the baby getting the vaccine, it shows that the protection may wane a little bit more slowly than from the maternal RSV vaccine. They get the direct receipt of antibodies and they don't have to rely on that transplacental transfer. And because they get it after pregnancy, there's no risk for adverse pregnancy outcomes. A disadvantage is it does require giving the infant an injection, and there could be a delay in administration and it could leave the baby from getting vaccinated, and it leaves it unprotected. So as we prepare for the next RSV season, we can be certain that we are going to be hearing this question: should a pregnant person receive the maternal RSV vaccine during pregnancy and subsequent seasons if they got it during the previous season? And currently, the answer is no. Instead, in that situation, the infant should be receiving nirsevimab. There are ongoing studies looking at this, and that may change in the future, but currently the recommendation is just to get it the one time during pregnancy. Looking at flu in pregnancy and flu vaccines, the annual epidemic of influenza is caused by two different types of flu. And I'm sure we hear all the time, I got the flu shot last year, why do I have to get it again this year? And the reason is because there is that antigenic drift, and the vaccines can be a little bit different each year to try to help protect against the strain that's the most common, the strains that are the most common for that season. So pregnant women are at an increased risk because of, as we mentioned before, the changes that happen during pregnancy. Pregnant women and their babies are at an increased risk for complications such as pregnancy loss and reduced birth weight, preterm labor, preterm birth, hospitalization, and even death from the flu. Pregnant women are more likely to be hospitalized and die from the flu than women that are not pregnant. And just anecdotally, when I was a resident, I'll never forget a patient that we had. She was about 30 weeks pregnant. She came to the emergency room with the flu. She hadn't had the vaccine, and she was having respiratory symptoms. And my very wise attending immediately had her admitted to the ICU. And that morning when I was rounding on her, she just needed nasal cannula. She was talking with us. But by that evening, we were doing an emergent bedside C-section because she had decompensated so rapidly and went into cardiopulmonary arrest. Thankfully, both she and the baby survived and left the hospital intact. And it gave me it really made me very, very aware of how profound an impact the flu can have on moms and babies. So looking at infants, infants less than 6 months old have the highest risk for hospitalization with influenza. And these are the little ones that are too small to get the vaccine. And that's why it's so important for moms to get the vaccine and give those antibodies to their baby for those first months. Women who get the flu vaccine while pregnant or breastfeeding develop those antibodies, and they can share those with their infants also through the breast milk. And so this is another incidence of where breastfeeding can provide some protection against the flu for infants and can be important in those that are less than 6 months old when they can't receive the vaccine. So recommendations for pregnant people: the flu vaccine can be given at any time and any trimester during pregnancy. Ideally, they should be offered in September or October, but you can continue to give it throughout the entire flu vaccine. And it's something to consider to give it a little bit early, like in July or August, for pregnant people in their third trimester to try to help optimize protection for their infant during the upcoming flu season. One of the issues that can occur with this, though, especially in my clinic, is we don't usually get the vaccine until September. Looking at the safety, these flu vaccines are safe in pregnancy. That's the bottom line. Both the CDC and ACOG recommend that pregnant women get the flu vaccine. It's been given to millions of pregnant women over almost 5 decades and has been shown to be safe. There's just so much evidence that's out there. The CDC and ACOG both give it the thumbs up. Looking at the effectiveness in pregnancy, the flu vaccine in pregnancy, the effectiveness is similar to the efficacy among the general adult population. We do know that it has a 50% reduced risk of flu-associated acute respiratory infection in pregnant women, a 40% reduced risk of hospitalization in pregnant women, and a 72% reduced risk of hospitalization in infants that are less than 6 months old. This is data that was presented at an ACIP meeting in October 2023. And I was looking at the effectiveness of maternal influenza vaccination during pregnancy against influenza-associated hospitalization and ER visits in infants. And as you can see, it did show that there was an effectiveness for those less than 6 months of age, and especially for those less than 3 months of age. So this has been a good review of the different ways that we can, the different types of vaccines available in pregnancy. Now let's move on to communication tools that can improve your vaccine conversations. So as we've said before, prenatal care providers are the most trusted source for the Tdap vaccine, COVID, and flu vaccine. And data backs this. There's further data that backs this up. Sorry, I'm trying to get on to the next one. But the most common thing that is going to cause these women to get the vaccine is to have a provider recommend it. And unfortunately, we are seeing a lack of provider recommendations. During the 2023-24 flu season, only 1 in 4 women were recommended to get the flu vaccine, 1 in 5 the Tdap vaccine, and 2 in 5 were only recommended to get the updated COVID vaccine. So just that reminder that vaccination coverage is highest among pregnant women that get a provider offer or referral for vaccination. So we need to be recommending it to these women. They are listening to us. So we've established that it's important that we recommend these, but we do also know that when we address vaccine hesitancy, this is not a one-size-fits-all approach. So when we think about a patient's hesitancy or even our own hesitancy for making a change in a health behavior or accepting a vaccine, we'll often find ourselves in this continuum of resistance conundrum. And we can basically split this into thirds. So on the left, we have our patients that are not at all hesitant. These are patients that are calling my office in July asking when they can get the flu vaccine. On the right, we have the patients that are just absolutely not going to get the vaccine no matter what you say. In the middle, we have the ones that could use some motivation and could be swayed to getting the vaccine. This is called the movable middle. And we notice that, so we can use this technique when we notice some hesitancy or ambivalence, and we need to go from just kind of letting them know, yep, we're going to give you the vaccine, to being able to help them realize why they needed the vaccine and helping them make that decision. The bottom line, though, is we don't want to force this, and we don't want to make that relationship suffer because of our recommendation for the vaccine. We always want to preserve the relationship with the patient and improve that relationship where possible. So let's get on here. So an example of presumptive vaccination, we can say something like, I strongly recommend that we protect you and the baby today by getting the vaccine against flu and COVID-19. And for someone that is open to it, this is usually all we need to do. This is versus saying something like in participatory language of, are we going to do shots today? And an example of this would be if you took your child to the pediatrician and they tested positive for strep throat, they would say, your child's tested positive for strep and we're going to give you a prescription for amoxicillin. I didn't usually hear your child tested positive for strep throat. Would you like to have a prescription for amoxicillin to treat it? So the presumptive language can be very helpful in that population that are willing to receive the vaccine. It works, and it's similar to other recommendations that we make, and it saves time. We can just say, I think you should get the vaccine, and they're agreeable to it, and we can move on. So I am sure you are all a little tired of hearing only my voice. And so I have employed the use of the talents of one of our graduate assistants, who also happens to be my niece. All right. So based on the information we just covered, would you give this a thumbs up or a thumbs down? So Mackenzie, as part of your prenatal care today, you can get a Tdap vaccine. What would you like to do today?
I think we will skip that today. One less thing I have to do.
All right. So is this a thumbs up or a thumbs down? This is a thumbs down. This was not an example of effective communication. Versus, Mackenzie, as part of your prenatal care today, I strongly recommend the Tdap vaccine. I recommend this to all my patients at the 28-week visit. It helps to provide the baby with the best protection against whooping cough in the first few months of life. Do you have any questions?
No, that sounds good.
All right. So this is a thumbs up. It's a solid presumptive recommendation made with confidence. And when you have confidence, it instills confidence in the patient. Do you feel confident?
I do.
All right. All right. But what if presumption doesn't work? Well, we've got this thing called motivational interviewing that has been shown to be very effective. It was developed in 1983 by clinical psychologists, and it was actually originally used as a way to do brief intervention for problem drinking. One of the creators said it was to elicit from patients their own good motivations for making behavior changes in the interest of their own health. So motivational interviewing, it's evidence-based, and it's a patient-centered way of starting a conversation that builds a patient's own motivation and reason for change. We kind of all know if we want to do it ourselves, we have a better chance of it happening. So it's done by exploring and resolving their doubts and uncertainties, and at the same time respects their decision-making capacity. And many strategies in medicine involve providing corrective information and education, and that can be really helpful in some situations. But I'm sure many of us have experienced this approach can also backfire. And when it does, it can leave both parties feeling really unheard and frustrated. In contrast, the goal of motivational interviewing is to make people feel respected and heard and more likely to consider the recommendations from trusted providers and helpers. But of note here, motivational interviewing is most helpful when people do have some ambivalence. If they're really absolutely against it, this isn't as helpful. So motivational interviewing is really for those people that are in that movable middle over on this side. So I know you're probably all thinking, that sounds great, but I've got like very limited amount of time and hardly have enough time to get through what I already need to get through in an OB visit. So how am I going to do motivational interviewing? Well, it doesn't need to be all at once. In my practice at the new OB visit, I just briefly go over the landscape of what care for the pregnancy is going to look like. And I make sure I include that at 28 weeks, we give the Tdap vaccine. And I can get an idea of how they're feeling about vaccination from how they respond to that, and gives me an idea of what we should do going forward. And if they seem more hesitant, we can kind of talk about it a little bit each visit, so it doesn't all have to be done at once. Some communication techniques that you can use for this are open-ended questions, like, you aren't sure about the flu vaccine today, what worries you? And let them tell you what they're worried about. You can reflect back. You are really worried about the ingredients in the vaccine. You can honor their ambivalence. And so you don't want the baby to get pertussis, but you're also worried about how safe the vaccine is in pregnancy. Many people feel that way. Make sure to ask permission to share, and then make a strong recommendation. If you feel comfortable sharing about yourself, you could say something like, during my own pregnancy or during my partner's pregnancy, they received a Tdap vaccine, or I recommend this to all of my patients. But then also at the same time, support autonomy, because it is your body and it is your decision. Another motivational interview technique is called use scaling questions. So for an example, on a scale of 0 to 10, how important is it for you to get the Tdap vaccine today? So this ruler that's on the top from 0 to 10, if they're in the 0 to 3, you don't really need to do a whole lot because they're probably quite motivated. But in the 4 to 10, you could dive a little bit deeper and to see what would be their motivation for change. You can ask things like, why did you say 5 and not a lower number like 3? Or what could make it higher? What about what could you do to a 6 or a 7? By doing this, it enables the patient to reflect on their concerns and their motivating factors for change. So, doing a case study here. So, great to see you, Mackenzie. I see that you're here today for your 28-week visit. As part of today's visit, I strongly recommend the Tdap and flu vaccines to ensure both you and your baby stay healthy. Do you have any questions?
Excuse me. You know, I'm really uncertain about getting vaccinated during my pregnancy. One of the influencers I follow on Instagram shared how particularly unsafe vaccinating in pregnancy can be for the baby. Specifically, she said that it can cause early delivery and possibly even stillbirth. I know she isn't an expert, but I trust her opinion, and the things she shared really scared me.
So some good things during this that the provider did is used a good job of presumptive language. And once the patient expresses concern, then we should reply with empathy and honor their autonomy. So we could say something like, you aren't the first person to bring up concerns with this. Can I share some information with you?
Absolutely.
Right. And we're going to skip over this just because of time, but being aware of and up to date of the facts of the vaccine allow you to answer questions like Mackenzie just had in that case study. And we've gone over all of those today already. And wondering, how is the vaccine safe and how is it monitored? There are many ways that it is monitored. There are ongoing safety monitorings all the time with the Vaccine Adverse Events Reporting System, the Vaccine Safety Data Link, and vSafe. And you can tell patients about these if they have real concerns about the safety, but knowing that initial data and being able to give them a quick overview can often allay their fears. And the question often comes up with my patients and even with my staff, is it safe to give the vaccines together at the same time? And the short answer is yes, it is. There hasn't been any, with the studies that have been done, it's shown that it's safe, that and it's just as safe as if you were to give them separately, and there haven't been any issues with birth outcomes or significant reactions with the two being given together. So moving on, say something like, when we are talking to Mackenzie here, we want to show that we're actively listening and make sure to lead with empathy and use clear and concise information. So I could say something like, vaccinating during pregnancy is safe for both you and baby and is one of the most important things that you can do to help protect your health. I understand that you read or heard from the influencer that you are following that it could lead to problems with the baby. And hearing the word stillbirth is very scary, but I can reassure you that many studies have been done, and none of them have shown an increased risk for miscarriage, preterm delivery, or stillbirth. Do you have any questions about that?
No. Thank you so much for sharing that. It is a relief that this has been looked at extensively and that you're confident about their safety. But my one question is, how does this benefit my baby?
Oh, that's a great question. So again, we want to lead with empathy and use clear and concise information. And so, Mackenzie, the flu can be very harmful to both you and to the baby. And so that's why we feel it's so important for you to get the flu vaccine during pregnancy. When you get the flu vaccine, those antibodies that your body makes can cross the placenta and go to the baby and actually help the baby. Those little ones are so at risk of getting very, very sick right after birth, and they can't get the vaccine. So when we give you the vaccine, that helps protect the baby right after it's born. And so by getting the vaccine, you're helping you and you're helping your baby. And it's been shown to be very, very safe. All right. What do you think about that?
Your recommendations are very important to me and my baby. And I think I just need a little bit more time to think about it.
All right. So what do we do when a patient declines? Well, we can address it at a future appointment, and we can get them some information so that they can read through it and can get themselves more educated as well. So I could say something like, absolutely, we can talk about this at future visits. Can I get you some information so that you can read more about it at home?
Yes.
And information that is well structured and maybe not from an Instagram influencer.
Yeah.
All right. So what other things can we do to increase vaccine coverage in clinic? Well, here's a couple of other tools and tips. So we can do reminder and recalls. And so when immunizations are available, we let patients know that. We can do clinical decision support tools, like things like standing orders, order sets, the care gap. That is that little thing that I need to pay more attention to. If you have an electronic medical record, it's specifically with Epic over on the left side, it comes up with the care gaps and will tell you which vaccines the patient is due for. And then you can continue to recommend vaccinations to unvaccinated patients. You don't want to pound this at them, but you certainly keep bringing it up and answering any questions that they have. And I've certainly had patients that have said things like, this is the third time you brought it up. It must actually be really important, so I will get it. And so sometimes just being persistent, you don't have to be obnoxious, but persistence can help to get more people vaccinated. Then you can close the care loop with pharmacies. In larger cities, that's harder to do, but especially in smaller communities, you can get to know your pharmacy immunizing partners and collaborate more with them to help people in your community. And if you are sending a patient out to a pharmacy to get the vaccine, if you write on the after visit summary, or if you send the prescription, you can write the risk factors that you've already gone over. You can write their pregnancy status, including their gestational age, and you can write specifically during pregnancy that it needs to be the Pfizer-Abrysvo vaccine. We've got a few minutes left here. Do we have any questions?
All right. So, being respectful of time, Dr. Tompkins, there was a couple of great questions that came up. One was, do we know, are there differences in vaccine uptake in people who are pregnant in rural and urban areas in North Dakota, or maybe in other rural states? And if yes, what can healthcare providers, including office staff, maybe do to increase vaccine uptake in people who are pregnant?
That's a great question. And when I was looking through the data, I didn't see any difference between rural and urban uptake of vaccination. Um, I actually do outreach to a rural clinic once a month, and I know out there they do a spectacular job of making pregnant women aware of the vaccines that they need to have and getting it to them. So I don't know about that, but I don't know specific numbers about that, and I haven't seen anything that shows that, but I do know from personal experience that the small clinics are really, really good, or the more rural clinics are very, very good about making pregnant women aware of the vaccines that are available and offering them to them.
Excellent. Thank you for that. Another question came in. It says, you said if they are born 14 days after getting the vaccine, baby is protected. So does the baby need another vaccine of Beyfortus if not born after the 14 days?
So if it has been at least 14 days from when the mom got the vaccine until the baby is born, they do not need to have they do not need to have another vaccine. If it's been less than 14 days since the mom got the vaccine, then the baby should get the nirsevimab.
Great, that's very clarifying. I know we're down to the wire. A final quick question, then we'll probably be done, is do we think that hospitals will get on board this season and start to give the infant RSV at the time of birth, along with Hep B before they leave? I know this has been a complicated issue, but curious your thoughts on that.
Yeah, I mean, we've certainly, I'm from the OB-GYN perspective, I'm on the OB-GYN side of things, but I have certainly heard discussion amongst that when I've been up on labor and delivery, and we're really wanting to. I don't know exactly where that is at, but the research certainly shows that it is very effective and helpful for preventing RSV in those little ones. And so I'd be very hopeful that we'll get on board with it.
Yes, as a pediatrician, I couldn't agree more from our side. I know there's been funding and insurance company issues in being able to include that in the sort of delivery bundle at the time of the nursery stay and discharge. So I believe that is the holdup, but every day those babies wait to get in with their pediatrician, puts them at risk. So
Absolutely.
well, we are at 1 o'clock. Thank you so much for joining us. And we look forward to everyone joining us in the future for future series webinars. Have a great day, everyone.